tell me one thing that what is the first and foremost indication for you for the MIGS about the trabeculectomy when you decide that you would not do the trabeculectomy in this patient and you will do the MIGS?
Yeah, so it started off when I wanted to actually operate a uveitic glaucoma patient with open angles and strong steroid responder, as ankylosing spondylitis, has multiple systemic problems, and coming back to the hospital was a problem. His disc was healthy, pressures in the 50s, not coming down at all. So I really thought, is it worth doing a trabeculectomy? I can't let go because his pressures have not been coming for the past many, many months. So that is the first case that I did a GAT, and I was so happy for him that I think I have about 8 months or 9 months follow-up, and he's off medications, pressures are 16, and he just has to come and see me once in a few months. So indication for me is anybody who requires an IOP reduction with open angles and obviously not coming down with medications is an indication. So steroid-induced glaucoma, uveitic open-angle glaucomas, primary open-angle glaucoma, juvenile open-angle glaucoma, I would actually do, unless it is an advanced glaucoma where you require a really, really low intraocular pressure. So that is one indication for me where I don't want to do a GAT. Advanced glaucoma, IOP control with 3 medications, 4 medications, I'm doing a cataract surgery, I will combine a GAT along with it. So whether it is the KDB or the GAT, we don't lose anything. In fact, when I operated this gentleman who had a previous trap that failed, so I mean, I never expected that his pressures would come down so well and he will not require a medication. I was mentally prepared to give him at least 2 topical. Anyway, I'm going to stop PG analog post-operatively. At least continue 2 anti-glaucoma medications. If pressures are controlled, I'll be happy. He is off all medications, pressures maintained at 14. So that is what, so how long, I do not know. I think we are just learning. As time goes by, we will come to know. But to me, even if it means that I have to delay surgery, I would still be all right because I haven't touched the conjunctiva. All it takes is 10 to 15 minutes of your additional time.
Okay, thank you. And I would
like to ask one question, Pratik. Shirisha, if a patient has a previous surgeries done, like conjunctiva is not healthy, scarred, are you going to perform this surgery, and is it going to work? Because you said no, all aqueous plexus is going to be supportive in this system for the success.
Yeah, so the scarred conjunctiva, does it have a role in scarred conjunctiva? Subconjunctival vessels, I think, are still present. So when I said the outflow system, we are talking about the trabecular meshwork, Schlemm's canal, collector channels, and the aqueous veins and the lymphatics. I don't think they are scarred. It's the tissue that is scarred, the conjunctival tissue that is scarred. I don't think that's an issue. In fact, recently, a colleague of mine actually did a case post-VR surgery with a little bit of silicone oil emulsified bubbles in the superior quadrant, absolutely no conjunctiva, chosen for a TSCPC. Did a gonio to see if the angles were open, went ahead and did a GAT, and that patient was doing so well. Imagine doing a tube in this patient with conjunctiva, you're not able to close and struggling is a huge challenge. So what I'm saying is, it is a dream for all of us to be able to do a safe procedure in this complex size. So how much it works, how long it works is something that maybe next year when we have a meeting, I will tell our results. But I guess it is definitely very, very promising.
Thank you. Here I would like to involve Dr. Devan and Dr. Sirish. They are there. What is your experience with the mix, and how do you see its future in India, where it has a steep learning curve and the cost is a factor? Devan, first you take up this question.
Yeah.
Murli is also here.
I think so. Basically,
the brief because we have just limited time.
Yeah. So specialized situations or special or individual situations, as Sirisha pointed out, yes, we should keep these in mind. They are an added tool in our fight against glaucoma. But because most of the surgeries that we tend to do here will be for advanced glaucoma, there is a limitation with MIGS, and also the cost factor. So I think barring a few of them which Shirisha presented, the others are not going to be, for the masses. Sirish, what do you have to say?
Personally speaking, I had been using expressions quite before when they were introduced at that time in the beginning. Of course, now they're being used much lesser because of extrusion related things and all. What I was feeling is anything with lumen, which connects the inner part and the outer part, somehow have a high degree of unpredictability is what I felt. Of course, we have the other side, like, where we have the Ahmad glaucoma valve and shunts. But there, the difference is the tube is very, very long, and then the aqueous is pushed all the way till the mid of the globe. So you sort of over a period of time, the bleb that is formed because where the plate is, that forms something like a retainer so that there is no shallowing of AC. But otherwise, any connecting devices have a problem. But of course, the newer MIGs, we have to see. But one thing that bothers me is most of the MIG surgeries, if we see the studies, they are compared in IOP reducing capacity, not to a trabeculectomy, but to IOP reducing capacity of a plain cataract surgery. So I think probably long term is something we need to see. I'm not commenting.
We just have a few seconds. Can you say something?
Yeah. Hi. So sorry for coming in late. I was stuck with another program. A very quick comment about the MIGs in India. I think as Sirish pointed out, all the other conventional standard international MIGs are too expensive for our use. We only have to modify to the extent to which we use the Prolene suture or use the bent needle kind of thing, which Arvind Pondicherry has described. I think the MIGs would definitely, I have been doing MIGs for some time now with the Prolene suture. I do find it will work to a mild to moderate extent. It will not give you very low IOPs. A lot of practical, technical difficulties are there because we've been doing traps for so many decades. We can't match the experience of that with the MIGs. We're going to take some time to adapt. But I think MIGs is the future, and there are definite indications for MIGs. And cost is going to be an issue in the Indian scenario. We have to modify ourselves to the Indian scenario and consider cost-effective options for mild to moderate glaucomas combined with cataract surgery maybe. But for advanced glaucomas, I think clearly we should not venture into MIGs, at least for now.